Welcome to the Wax Ultrasound Basic Echocardiography unit. In this module, we're going to run through the basic sonor anatomy of the heart, and we're going to look at the different views and the different slices that we can take of the heart in order to get the maximum amount of information about the patient by looking at the heart in multiple different views. Now, the heart is in quite a variable organ. It can be in different places in different people, and the shape of the chest can make a big difference. So, for example, people with cor pulmonale and pulmonary hypertension tend to have a very long, drawn-out mediastinum, so their heart may be tricky to see on the anterior views. However, it may be more easy to see on the subxiphoid views. So, this is all assuming that the patient has normal anatomy, and we're going to look at 3 different windows through which we can achieve 5 different standard views of the heart. Now, the first window that we like is called the parasternal window. The parasternal window is usually located in either the second or third rib space, though it can be lower down in older people or in adults or very tall people. And the trick with finding a parasternal window is to put your probe as close as possible to the sternum, but not on the sternum. Just slide off the edge of the left side of the sternum, and then look in that rib space and see if you can see the heart. And if you can't, you quickly slide up and down different rib spaces until you get a window which gives you a good view of the heart. Don't spend too much time looking in one window. If you can't get it through that rib space, just keep moving until you find a good window. As I said, everyone's a little bit different, and once you've found that window, that is the window that you're going to use for a lot of your views. So you need to keep as close to the sternum as possible and have a look. Okay. The other views that we're going to look at are the apical view, which is usually done at the point of the maximal apical impulse, which we would all be able to identify clinically. But once again, it's usually down around the level of the nipple and can be in different locations depending on the shape of the chest. And then the last window we're going to look at is the subxiphoid window, which is obviously, as in the name, just underneath the xiphoid process. All right, let's have a look at how these windows look. When you first approach the patient, it's usually easiest to get the parasternal window, and the long axis is with the probe marker pointing towards the patient's right shoulder. So in this view, we'll be able to see a long axis of the left ventricle, hopefully, and the view is actually backwards on most cardiac presets. So although your probe marker is pointed towards the patient's left shoulder, the apex of the heart will be on the left of the screen, which is the opposite of what you would think in your head. But if you just do it the same every time, it will make sense. And then if we want to get a short axis view, we can just rotate the probe through 90 degrees so it's pointing towards the patient's left shoulder. And at this point, we'll have a short axis view. And in the short axis view, we tend to fan the probe up and down whilst trying to stay as close to the sternum as possible and not sliding too far, because we'll hit lung usually if we do. So trying to tilt the probe and fan to look up towards the base of the heart, and then down through the mid part of the heart, and then once again down towards the apex of the heart. So sort of fanning through the heart whilst trying to maintain that keyhole window that we're looking through. The next move is we take the probe off, we find the maximal apical beat, or where we think it may be. It's usually just lateral to the nipple. It can be very useful to roll the patient for this view onto the left decubitus position. And for women with more breast tissue, it can be very helpful for you to get them to take their right hand while they're laying on their left side and just gently lift their breast up and away from the ribs. So it's sort of elevating the breast up so that you can get under that breast, because usually this window is somewhere near that fold where the breast joins the chest wall. So that can be quite useful if the patient can help you. And once we've found that window, usually there's a few different slices of the heart we can get in the apical. We can get the classic 4-chamber view with the 4 chambers on view. If we just fan a little bit anterior posterior, we can get the 5-chamber view. And then if we rotate completely 90 degrees in the apical window, we can get a 2-chamber view, which we don't really use much in bedside echo, but is a view that is used for measuring the left ventricle. Lastly, we're going to go down to the subcostal window, or the subxiphoid window. And this one, we usually want to start with the probe with a hand on top of the probe. So we're sort of holding it in a very different way so that we can scoop up under the ribs and under the sternum and flatten the probe right down so that we're looking up into the chest. So the probe's almost horizontal when we're doing this view. It can help with this one to get the patient to take and hold a deep breath if they can do that. And we're trying to get that picture usually with a little bit of liver in the foreground looking up towards the heart. And once we've got that window, we can also use the same window to rotate down and then be more perpendicular to the bed and look at the IVC. So what do these actually look like? So here's our parasternal long axis view. This is what the standard picture would like to look like. And what we would like to see is a little bit of the right ventricle, or it's actually the right ventricular outflow tract that you're seeing on this view, the base of the aorta or the root as it joins onto the aortic valve, and the left atrium and mitral valve in the far field. And if you've got a good view on the parasternal long axis, you should be able to see all of these structures lined up, and they should all be roughly the same size, usually around about 2 centimeters in diameter. So RVOT, aorta, and left atrium all stacked one on top of the other. And if you've got this view well aligned, you should be able to see the aortic valve and the mitral valve in the same plane. So you know that you're right in the mid-chamber of the heart. And that's a good view to have if you can get this standard view. You'll also see a little bit of the descending aorta in cross-section in the very far field just behind the left atrium. So if you can see that, then that's another way of viewing the aorta as it comes around behind the heart. You may need to fan your probe towards the apex or back towards the base. It's quite common that you cannot see all of this view in one particular window, and often you need to fan to get to the apex or fan to get down to the base. But generally, if you stick with that parasternal window and just tilt your probe a little bit, you can get most of the heart at some point. And this is what it looks like. So I'll play the clip here. We'll just repeat that over and over. Here we've got a nice picture. This is the RV outflow tract at the top. You can see the aortic valve with the little cusps coming together there in the center, and the left atrium here, the mitral valve flicking away there as the blood pumps into the left atrium, left ventricle, and the descending aorta is this circular structure at the back. The bright white line here we train our eye on as the pericardium, and there's no pericardial effusion because you can see the muscle up against the pericardium, so there's no fluid there. And it's a great view for getting a look at the overall left ventricular function. You can see most of it here, looking at the septum and also looking at how the valves are moving. There's quite a lot of things that we can measure, and we'll come back to that in future talks. Now, when we turn into the parasternal short axis, we're looking at the same window, but we're just looking at an orthogonal view, so 90 degrees, and we're fanning from the base of the heart, which is the top left picture here, where you can see the aortic valve with the various coronary cusps, the left atrium, the right atrium, and if you get it right, you can see both the pulmonary and tricuspid valves as well. This isn't an image that we use a lot in point-of-care ultrasound, but it can be useful when you start measuring things as you get more advanced. But that's what it looks like if you've got the aortic valve doing the Mercedes sign right in the center of the screen. If you just tilt just a centimeter or so you're tilting the probe, trying not to slide, trying to stay in that window, you can get this top right picture, which is the fish mouth view of the mitral valve. So you're seeing the mitral valve as a fish mouth from end on. You can see the septum, and this is a really good view for comparing the right and left side. And this is, of course, the view where we try and compare the right side to the left side in terms of pressure. And if there's a D sign, you'll see that septum, instead of being nice and round, will get flattened, suggesting high right-sided pressures. So this is a really good way for looking for that RV discrepancy in pressures, and also for looking at the various segments of the heart, because you can see most of the segments of the heart in the parasternal short axis. And then as we slide down a little bit further, you get to the mid-papillary level, so you can see once again the RV and the LV, and you can get a good look at how the LV is thickening. And if you slide right down, you get the little donut. That is just the apical segment once you get past the papillary muscles. So those are the standard slices that we like to get through the left and right ventricle in the short axis view of the parasternal window. And this is what it looks like. This is, of course, the mid-papillary view. So you can see the papillary muscles here at the posterior part of the heart. A nice round circular left ventricle, which is contracting nicely, coming in towards the center. And then the big floppy right ventricle sitting on top with quite a thin wall and moving away there. And so that's a standard normal mid-papillary level view of the parasternal short axis. Alright, now we move down, pick up our probe and go down towards the apex of the heart. The trick with this is to try and line up the heart so that you've got the apex, the true apex of the left ventricle usually, at the top of the screen. So you're looking your probe's as close as possible to the true apex of the heart, and then you've got to angle the probe to try and make that septum as vertical as possible on the screen. Now you can sometimes fan around a little bit and rotate a bit to make it vertical or to get more of the left or right, depending on which part you're currently looking at. But a really good view, you'll be able to see all 4 chambers on the screen at the same time. And that's the classic apical 4-chamber view, which is really good for looking once again at the relative size of the left and right ventricles, and also for looking at those valves, because this is the view where you're looking at the valves dead on, straight down the barrel, so you can get some good Doppler measurements on this view. Not that we teach that on this course, but it's a very useful skill if you can get this view. If you fan just a little bit towards the front or the back, you'll get different slices through the left ventricle and right ventricle. And if you can see the left ventricular outflow tract and the root of the aorta, that's called the apical 5-chamber view. And then if you take that view of the left ventricle and rotate 90 degrees, so you're excluding the right ventricle now, you're just looking straight a slice through the left ventricle and the mitral valve and the left atrium. That's called the apical 2-chamber view, which we don't use a lot in point of care, but this is the view that we use for doing estimation of ejection fraction when you use Simpson's biplane. So not something that you need to know for point of care, but good to be able to do all the same, just so you understand what those reports mean. So this is a nice apical 4-chamber view here, maybe even a 5. You can see a little bit of the aortic outflow. So big left atrium, maybe a little bit generous, left ventricle at the top here, and then we've got the right ventricle on the left of screen. Remember, it's always backwards in cardiology, and the right atrium down in the bottom left corner. And so this is a good view for looking at those 2 different ventricles, comparing the sizes of all the chambers. You can also see effusions on this, and it's quite good for looking for pulmonary hypertension, where you may see the septum bending in towards the left ventricle. And finally, we've got the subcostal window, and in this window it's really good to try and get some liver in the foreground. So you get your probe under the xiphoid process, usually slide it back away towards the liver a little bit on the right side, and try and get a slice of liver, which is a good acoustic window to look through and into the right ventricle. Now you may need to drop the depth down because it's quite a deep view, and often patients will be 15 or 20 centimeters to get this view. So you may need to drop the depth on your probe, and you may need to increase the penetration, so decrease the frequency to get a good picture. But each patient's different. Have a fiddle with it. Now on this view, it can be a little bit confusing, but essentially we're looking at a same view as the parasternal long, but flipped over the other way, if that makes sense. So we're looking at a view from under the heart, and we're looking back up. So the first thing we get is the right ventricle, which is at the inferior part of the heart, and then we've got the left ventricle in the far field, right atrium, left atrium, and this is a good view for, once again, comparing the 2 sides. And this is a good view to be able to achieve because it's pretty reliable. You can get it in most people. This is the view that we look at when we do FAST exams, for example, for looking for pericardial effusion. And it's also a really good view for people with advanced lung disease, because it's quite often tricky to get really good parasternal views or apical views on people with a lot of emphysematous changes and bullae in their lungs. So this is usually quite reliable in those sorts of patients. We always try and get all the views because you can't really make a good call about the heart on a single view. So that's what it looks like there. Liver in the foreground, the big chunky solid-walled left ventricle in the far field, the smaller floppier right ventricle in the near field closest to the liver, and the septum in the middle. And then of course you can see the atria filling as they come into the heart. Now if you take your probe from this view where you're looking up into the chest and then sort of rotate it around so that you're heading down back into the bed, you'll get this view, which is the subxiphoid view, but looking down now through the liver at the IVC. Now often you won't be able to see all of this, you'll just be able to see the right atrium and a slice of the right ventricle, but what you're really looking for is to get a true long axis view of the IVC, and ideally you can see the hepatic veins, because that tells you that you're definitely on the IVC and that you're sort of in the midline hopefully. And we tend to measure the IVC just distal to the insertion of the hepatic veins into the IVC in the back of the liver there where the little arrows are. Now there's a lot of evidence and a lot of argument and debate about the value of measuring IVC, but it's certainly something that is worthwhile doing. You can look at respiratory variation. You can do an eyeball, or you can actually ask the patient to take a deep breath in. You can use measurements, but generally speaking, it's useful when it's at extremes of range. So if you've got a very flat, collapsed IVC, one that you can barely see, there's a good chance the patient has a low central pressure. If it's in that middle range, 1 to 2 centimeters, it's collapsing a bit, we don't really know what that means. And if it's really big and not moving at all, that does suggest some sort of obstructive component. It doesn't tell you what it is. It could be they've got a big PE, it could be that they've got a tamponade, or it could be that they've just got really high chronic right-sided pressures from their pulmonary hypertension. So it's always hard to tell, but it's worthwhile getting into practice, looking at these things and accepting that at the extremes, so very small and very big, the IVC probably does help you, but you have to integrate this with everything else that's going on with the patient, their echo, their ECG, everything else that you know about them. All right, so that's the basic sonor anatomy. You need to do this regularly. You need to practice with hands-on if you want to get good at this, and it can be quite frustrating when you're learning, but get the patient into good positions, roll them onto their left side. Don't forget that you may not be able to get all the windows in every patient, so you need to be able to move on and keep looking through the different windows until you get all the information that you need. And generally speaking, you can get 2 good windows in most patients, and in some patients you can get all 3 windows really nicely. So keep looking and keep trying, because you will get there eventually. All right, we'll see you at the workshop.